Hi, I'm William Ming, Quality Manager and Patient Safety Officer, and I'm here to talk with you about quality improvement here at JMH. So our agenda today is going to be talking about definitions first, and then we'll talk about why we're doing quality improvement and using quality indicators. We'll also talk about the regulatory requirements for the Quality Assessment and Performance Improvement Program, how to make your quality indicators more meaningful, and of course we'll talk about the quality indicators report itself. Our objectives today are to refresh your memory on some of the details of the QAPI program and to provide details for those people who are relatively new to this, and also to inspire you to have great quality indicators. So quality indicators are those norms, criteria, standards, and other direct qualitative and quantitative measures used in determining the quality of healthcare. So some examples of quality indicators are patient outcomes such as readmission rates, patient satisfaction scores, quietness at night, communication by staff, process measures which are completing specific patient education, for instance, or documenting patient vital signs. Safety events too, frequency of medication errors, or fall rates, for instance. Quality monitoring is measuring a process or outcome over time. Monitoring is done for quality not known to be less than desired or required. Monitoring is also done because you want to closely watch some important process to make sure that it stays within the correct threshold. So for quality monitors, further action is not required unless the monitor does not meet a predetermined threshold. Performance improvement is also monitoring, but performance improvement is not called a monitor. So measuring and improving the quality indicator over time, rather than just measuring the quality indicator over time. So that's the difference between a monitor and a performance improvement project. When you're doing performance improvement, actions are required to improve the quality of the being measured. We use the PDSA process, and we'll talk more about that in a moment. So performance improvement projects must have a predetermined goal, so different from the threshold of a monitor, must have a predetermined goal which indicates successful improvement. Performance improvement is initiated to improve quality which is known to be less than desired or required. Now, what I mean by known is that you can actually display what you know. So just thinking that you have a process or outcome that is not meeting your expectations is not quite enough. You need to do some monitoring so that you have data, so that you have documentation to show that, yes, I have a reason to do performance improvement. So again, a goal is for performance improvement projects. And the goal itself tells everybody where you want to be with expected performance. A threshold is for monitors. It's also expected performance, but we set that threshold as a determinant of when PI, performance improvement, might be necessary. For both goals and thresholds, we can use different data points. So we can use a benchmark, which, by the way, is the best goal or threshold to use. A benchmark is a measurement used as a standard by which to judge similar measurements. We might get these from professional body expectations, but I want to point out that this is not just average performance. So when a professional body sets a benchmark, it might be the average of performance among a group, but often it is higher than average. It is an expectation that everybody meets that, and people might have difficulty meeting those benchmarks. Now, average performance, yeah, we can use that as goals and thresholds. It's a good goal or threshold, not the best though. We can get average performance from, say, peer hospitals if we have access to their data from CMS data, for instance, for national averages. We can also use our own baseline performance. So if we monitor a process or outcome over time, we can use the average to decide, do we want to be better than that average? If we do, we can set the goal or threshold a little bit higher than that average. We can also use that average to say we want to maintain this average in the coming years and continue monitoring and set the threshold as that average. So a lot of times we use guesstimates. Those are not a great goal or threshold, but sometimes we do need to use those because we don't have benchmarks, we don't have averages, and we don't even have our own baseline performance. So we set a guesstimate as a threshold for a monitor, and we might determine later that, well, our guesstimate of where we want to be was too high or too low. That happens frequently, so you want to avoid using guesstimates if you're able to do so. So now the relationship between quality indicators, performance improvement, and quality monitors are this. So you can see up here we have medication errors as an indicator, we have patient satisfaction as an indicator, we have patient outcomes as an indicator. So all of these things are quality indicators, but what you decide to do this is what differentiates them the most. You might decide, well, we're meeting threshold, we're meeting that expectation of performance, so we'll either continue to monitor, or if it's not that important to continue monitoring that process, then you might decide to just stop looking at it. And that's okay as long as you're meeting that threshold. For those things that aren't meeting threshold, you might decide that we need to improve this process or this outcome, and so then that quality indicator becomes no longer a monitor, but a performance improvement project. The Plan, Do, Study, Act, PDSA, that's the main method that we use at Johnson Memorial for quality improvement. It's a cyclic method, and it's used to perform improvements leading to outcomes or processes. So you can see this is cyclic. We start at planning when we do a performance improvement project. We plan an intervention to improve whatever process we're looking at. Then we do that intervention. We implement the plan of action. After implementing that plan of action for an appropriate amount of time, we study the results of the intervention. We look at the data. Does the data show improvement? Or is there not enough improvement? Or is it not doing anything at all? Based on those results, we act on the results. We adjust the intervention to fix the flaws. So if the intervention is kind of working but not quite to our satisfaction, we're not quite meeting the goal, we might just need to adjust it a little bit. That doesn't mean we have to completely throw it out. So sometimes, though, our interventions don't work at all, and that means we need to try something completely different. Also, we might find that we haven't spent enough time looking at our data or allowing the intervention, the action time to work. And it's appropriate to say, yeah, we need another month or so of data to look at that, to discover whether we're truly improving enough or not. One thing about this, though, is you cannot keep on doing this continuously, month after month after month. That's not improvement. So getting back onto our cycle, once we have figured out where our data is going and what we need to do, we need to plan how to implement that additional action or plan a new action. So again, we do that intervention, implement that new plan of action, study those results, act on those results, and keep on going around until we end up saying, well, we're studying the results and we're improving quite a bit. I think we have improvement. I think we have a good action plan. What we're doing is working. And then acting on that means that you are looking for sustained improvement at that point. So sustained improvement is going to be different for every performance improvement project. Sometimes you can see that you have sustained improvement in a couple of months. A lot of times, though, it takes about 6 months or so to make sure that not only have you improved, but you're keeping up to that goal. You're keeping up with that level of improvement, because people do tend to go backwards whenever they're changing. So you need to keep watching that for some time. So why are we using quality indicators? So quality indicators, they exist whether we're looking at them or not. If you're not using them, if you're ignoring them, well, they're still doing their own thing. They're still saying whether we have good quality of care or not. It's just that you're not looking at them. So there are so many quality indicators. You could look at all kinds of things within your department, but how do you decide what you want to measure? And that's really up to you, but, well, it's only kind of up to you. HVAP and CMS require measurement and improvement, but they want to look at very specific measures, and I'm going to cover that in just a moment. But actually, this is part of federal law that not only are we required to look at quality data, but we're also required to actually improve on processes and outcomes of healthcare. Also, quality indicators can allow us to demonstrate quality. So you might think that you have a great process, you have great outcomes. For instance, we have great hand hygiene rates. But if I don't have the data to back that up, then I can't show that to surveyors, I can't show it to others. I can't really be certain that we have a good hand hygiene program or we have good hand hygiene rates. So we do those quality indicators to collect data, and if you're doing well with that quality indicator, then fine. But you have to document that so that you can show others later, and so that you can show that we don't need quality improvement in this area. So HVAP requirements, again, in Chapter 12, which is all about quality, we have a condition of participation. A quality assessment performance improvement program is a requirement. We have to develop, implement, and maintain an effective ongoing hospital-wide data-driven quality assessment and performance improvement program. It's simply the law. Also for HVAP requirements, the Board of Trustees is responsible for QAPI, and med-staff must be involved. So the Board of Trustees, though, delegates the work of doing quality to the Quality Council, who then spreads that on out to the rest of the organization. So quality education also must be done for all staff, and part of that is done through annual education. But we also do some special education for those who are specifically involved in the leadership of the quality improvement process. That's what we're doing right now. Quality data collection house-wide, including contracted services. We have to have it for every department of the hospital. Everybody has to be involved in quality improvement. Now for both departments and contracted services, we have to have 2 quality indicators at least. This is a little bit different than what we did a couple of years ago because we only had to have 1 quality indicator. So HVAP has clarified their expectation that we have at least 2 quality indicators for every contracted service and department in the hospital. So we must have a process in place for measuring and tracking quality indicators. And of course, that's the quality indicators report sheet, which I'll talk a little bit more about in a moment. And this is very important. I'm going to touch on this a couple of times during this presentation. So we must show measurable improvement. We can't just look at data, do monitors, try to improve, not improve, and then say, we're not going to do that anymore. It's literally in the law that we have to show improvement. We also must show actions to improve. So it would be great if we look at something, monitor it, turn it into a performance improvement project, show that we have had improvement, but that is not quite enough. We also have to show what actions we took to do that improvement. And we have to document that. Again, Quality Indicators Report allows that documentation. Priority measurement for high risk, high volume, or problem prone areas affecting outcomes, safety, or quality of care. And this goes back to where I said that you kind of get to pick your quality indicators. Again, there are so many quality indicators. How do you prioritize those? Well, this is your list right here. You look first at those things that are high risk, high volume, problem prone, and especially those things affecting outcomes, safety, or quality of care. HVAP especially likes to see medication errors as being looked at in the organization. Of course, we're doing that. And you can do that on an individual department quality indicators as well. So HVAP Chapter 12, Element 00.04, Performance Improvement Project. The hospital must document what quality assessment and performance improvement projects are being conducted. Quality Indicators Report does that. The reasons for conducting those projects, again, documented in the Quality Indicators Report, and the measurable progress achieved on those projects. And when HFAP comes around to score us on this PI projects element, they look for whether we've achieved improvement in the first place, but they also look for, has that improvement been sustained? So it's not just a method of improving quality. It's not just the best way to improve quality. It's also an expectation of HFAP and CMS that we actually have sustained improvement. So how do we demonstrate compliance with accreditation standards? Well, the QI reports, of course, and we'll bring one of those up to kind of talk through it. So on this Quality Indicators Report, this very last summary page, all of your quality indicators and your data and your progress on those flows over to this sheet, and it automatically does that. So you don't need to mess with this sheet other than to use it as a summary for your own staff. We'll talk more about that too. So what I do with this is I take and copy your quality indicators, and I put them in a large sheet and send them to Quality Council, Board of Trustees, etc. So this is by no means secret information. We're going to be sharing this all over the place. So in the actual indicator sheet, you can see there's a lot of spaces for documentation here. As a rule of thumb, everything that is in green needs to be filled in, at least by the end of the year time period for each indicator sheet. If you have any green areas that aren't filled in, then that sheet is not complete. You need to put your department up there, and this indicator that's a drop-down box. So you need to select whether it's a performance improvement project or a quality monitor. The reason for this is if you have a quality monitor, then you have these set green areas. If you say, now this is a performance improvement project, and you can change it over time, then it opens up a lot more areas for documentation, and this is required documentation. So that's why I've highlighted these areas in green, so that you are reminded that you have to document something in these areas. If you don't, your indicator report is not complete. We can be cited by surveyors, and plus it's just bad for reporting up to Quality Council, and it doesn't provide the information needed for us to make decisions and talk about these quality indicators. So, indicator title, that just gives us a brief summary of what this indicator is all about. Departments involved. It's important to put all the departments involved because you might be working on something in your own department, which is fine to do, but if you're working with other departments and they are involved in this quality project, then you need to give them credit for that. And it's also good for us to know who to talk to and who to expect has responsibility for this quality indicator. Reasons for indicator selection. Remember when I was talking about those high risk, high volume, patient safety, problem prone ideas? This is where you document why you were selecting this indicator. If you can't select any of these items, then it's probably not a good indicator for you to use, for you to choose. So, and select all that apply as well. So if it's something that's high risk and is associated with patient safety, check both of those. So the formula to get the result. I get a lot of concerns about this, about what this really means. Whenever I say formula, it's actually a mathematical formula. So if you're getting a percentage, perhaps, then you would say numerator divided by denominator, and you would replace that numerator and denominator words with whatever those actually are in your indicator, and then equals the percent. So that's something like what I want to see. I want to see numerator divided by denominator equals percent. That's how I get my results. And how is the data being collected? That's just a narrative description of how you're collecting the data. And how did you choose the goal or threshold? Now this is something else that I get a lot of confusion on. It's not about why you chose the indicator. It's about how you chose the goal, the actual number. So if your goal is greater than or equal to 95%, how did you come by that? Was there a national standard for that, national benchmark? Was it the average of another hospital that you want to compare with? Or did you select that indicator or that goal or threshold on your own based on discussion with those involved? You need to document that in there. And just more about describing the indicator and the type of data being collected. And remember that these reports they're not specifically for you, and they're not even really specifically for me. I understand a lot about what you're looking at, so I don't need a lot of descriptions myself, but the Board of Trustees doesn't know what you're looking at, and they're not all healthcare people, so you need to explain very clearly what it is that you're looking at. Again, the summary goes up to the Board of Trustees, but if they want to look more closely at an indicator or the Quality Council, we will send them this information sheet. And so this is your chance to document the details of the indicator that you're looking at and what it means, why it's important to you, and what your expectations are coming from this indicator. So whenever you're writing these reports, write it for a Board of Trustees member. Write it for an HVAC surveyor, not for me. Now, over here, insert additional comments here. I realize these spaces are kind of small. This was designed to print out on individual pages cleanly, so I provided this other area over here where you can document all you want. And down here in the documentation of data section, you need to set, if you have, for example, a goal of greater than or equal to 95%, then fill each of those in so that we can see what your threshold or goal is specifically, or if it's less than 20 as a raw number, then you can put those in there, and then you come along and put your actual results in this column here. So sometimes thresholds and goals change based on how we're doing with those, and as we reassess how applicable that or how good that threshold or goal is. So I would advise that you just type in or document this threshold or goal as you go along. And over here is a smaller space for you to put any comments. What goes in the space for a monitor is different from what PI project. For monitors, just put in whatever comments you think are appropriate to explain your results. A lot of times it's good if you have a numerator and denominator to put both of those in there so we understand more about how large your denominator is and how that might be affecting your results. Of course, if you have a performance improvement project, those areas become green, and this has changed to not comments, but actions or interventions taken to improve. And that is because every time you don't meet that goal, over here in the results part, you need to say what action you're taking, because, like I said, that is a requirement not only of good quality improvement practice, but also of federal law, that you show what actions you're taking to improve. And there's also a space over here to document where you're at in the PDSA cycle for that month. And sometimes you're in 2 or 3 areas during the month. Just pick the major one that you're in for that month. Now, as you go down here, you can see some graphs that are automatically filled in with these numbers up here. Let me just add some data to show you what I'm talking about here. So you can see here in in the graphs that your goal shows up. So your goal is greater than or equal to 95%. And you can see that in the greenish colored line there. And then you can see your results in the JMH purple line. And that gives us a graphical indicator, a visual indicator of how you're doing throughout the year. And this isn't just for Quality Council, it's not just for Board of Trustees. This was designed so that you can readily print this out, share it with your staff, and use it for yourself to get a good idea of how you've been doing over time. So that's the very basics of the Quality Indicators Report. If you have any questions about that, please let me know, and we will go over it as much as you need to. So let's go back to the quality improvement presentation. So the purposes of these QI reports then, as I said, the progress reports are sent to the Quality Council, who decides what to do with that information and decides whether we need to ask somebody to come in and explain the results or act as a resource to those people who need some help with their quality indicators. We send it to Medical Executive Committee as well, and Board of Trustees, who I said earlier, they are responsible for the QAPI program for the hospital. And I would also like to take a moment to point out here that Board of Trustees, they are very involved in the quality program. They really look at these reports and they question when results aren't meeting what the expectations that they would expect. So please don't think that your quality indicators reports are just looked at by you and me. They go all over the hospital, and people do look very closely at those reports, which is a good thing. It's very good that they are involved. So making quality indicators meaningful. I'd like for you to use this process as it was intended for quality improvement. And I want that quality improvement to be meaningful to you. So whenever we go through the process of picking quality indicators, please don't think of it as something that we have to do and just another chore that you have to do. We want to have the highest quality of care possible here at JMH. And I would like for you to take a close look at what is meaningful to you in your department, what is meaningful to your patients, and pull quality indicators out of those things that are meaningful to you. Also, goals and thresholds need to not only be meaningful, but they also need to be realistic. Often we want to set a goal or a threshold of 100% on our indicators. Sometimes that's not realistic. So that means even if you miss 1 out of 10 or 1 out of 100, you're not going to meet that goal. If you continually do not meet your goal, that's frustrating. And it's also frustrating for your staff who are working towards that goal. It's often better to set smaller steps of goals and thresholds that you can meet, celebrate those successes when you meet them, and then raise the bar a little bit. And once you get up closer to 100%, then it would be more appropriate to set that 100% goal. But take your time with that. And of course, you need to involve your staff, not only in celebrating the results, not only in telling them this is how you're doing, but also what are we going to work on? What do we really need to improve in our department this year? Your staff are going to be the ones who are probably working on this quality indicator and trying to reach those goals and thresholds, so please involve them. That's very important. Talk with them about the process and ask them what their opinion is of what needs to be improved. I think you'll be surprised at how much they can share with you. And of course, as you're going along, share the meaning and progress of your quality indicators and your quality improvement with the staff. They need to know how they're doing. If they don't know that they're doing poorly or if they're doing well, then you can't really expect that anything's going to change with them. So if they're doing poorly, they're going to keep doing poorly because they don't know that they need to do something differently. And of course, very important, if you have success, then share that success with the staff who are doing the work. Celebrate that. Make it something important for them. and make them understand that you think it is important. So that's it for this quality improvement presentation, but I will be setting some individual meetings with all the QI leaders. And this is, again, to go over your quality indicators, go over your past quality indicators to make sure that they're all complete, and your current quality indicators to make sure that you're collecting the data that you need to be collecting and that you're doing well with that, and answer any questions about process improvement and ideas to improve, etc. This is not just part of the quality education process, but it's also part of making sure that we're ready for survey. So not only the current indicators, but also making sure your past indicators are all complete. So if you have any questions specifically about this, please give me a call. My extension is 2676. But as I said, I'll be scheduling all those meetings with you as well. So thank you very much. I appreciate your time, and I hope you have a great rest of your day.